We develop plans that are unique to each patient. We don't rely on the strengths of our clinic. We try to rely on their strengths to develop a plan. We try to meet them instead of them having to meet us. So, I look at this as I'm into sports, so the family doctor's kind of the head coach here, and the patient's the general manager. And then we're all part of the team with the family doctor and the patient, with the patient driving the car. I think I'm like a star quarterback. Fit, great arm, supermodel wife. Yeah, none of that's true except the supermodel wife thing. So if you'll call her and tell her, I'd appreciate that. So we got the patient there in the center, and then we're wrapping around from there, going outward. So the foundation is the relationship. We start with the primary care doctor, or a nurse practitioner, or physician assistant. And we treat everybody the same, no matter what the issue they bring into the table. We don't try to segregate out substance abuse and other mental illness and diabetes. We treat diabetes biopsychosocially just like we treat trauma. And you have to. How many people comply with treatment plans for chronic disease? General people. Anybody know? 50%, 75, or 25? Between 25 and 50. Yep. So we're probably missing something with diabetes if we're not paying attention to the psychosocial issues of diabetes. We even have a group that's made up of mostly people with severe mental illness and diabetes. And they're not all taking antipsychotics or anything, but they're all managing their diabetes, and they're doing a pretty good job with it. And that group's led by a family practitioner and myself, working together on all aspects of the condition. So our first floor, we have clinical coordinator, medical assistants, resource assistants, medical receptionists. We have counselors that all of our counselors are comfortable with any mental illness, including substance abuse. And then we have psychiatric prescribers that do a lot of evaluations, a lot of consults, and prescribing when needed. We don't prescribe any opiates or benzodiazepines or stimulants in the clinic because we feel like the location is too vulnerable when the person leaves. Not that we're totally against all that stuff, but if you're taking a stimulant in the homeless shelter, it's not real safe. Not real safe. We're all side by side. Everything is connected. Location's connected. We use the same record. It's an electronic medical record. It's instantaneous. So we have doors that are side by side, just like this. Primary care exam room, then we have a psychiatry office, and we have a primary care exam room, another primary care exam room, a psychiatry office, psychiatry meaning broadly counselor, psych nurse practitioner, psychiatrist, psychologist, whatever. We have to talk. Small hallway. We have to get along. We have to connect. So this is an example of what a patient could do in one day at our place. We only get paid for 2 of those things, though. So we also do this model called Psychiatry Integrated Primary Care, which we started at the Penobscot Community Health Care. And part of it is we'd like for people not to be able to tell the PCPs from the shrinks. So we are co-located, same system, one site, one vision, one budget, one message, all working together, whatever the issue is. We don't have any separate signs, no separate designations. We're all part of the same team. So our goals are to meet the primary care needs, destigmatize care, defragment care, collaborate in the moment, which is particularly important in the homeless shelter clinic because the window may be open only a brief time. So we got to do everything we can while it's open. And we also pay attention to finances, and that's important. So we talk all the time. So in one day, yesterday, I was in the clinic yesterday, Dr. Buck, our family practitioner, knocked on my door 3 times, asking me a question. I didn't take a long time, took 5 minutes. Answered the question, moved on. I went to her with 2 questions, one about a rash and one about lipids. She didn't spend a long time, but all these people got really good care. And they all appreciate it. They don't mind being, if they're interrupted, because they know it could happen the next day with them. We do a lot of pop-ins when people are concerned about seeing a psychiatrist or what we may be like, we try to pop in and reduce that fear, which is a very important part of what we do. A lot of team meetings, a lot of working together. Attitude, very important. Glad to see you, positive. Evening hours, meet people where they are. Try to help people work the system. We have a lot of good pieces. It's a hard system to work. We have electronic medical record. Everything is in it. Here's an example. The keyed visits are psychiatry or counseling visits. All providers can see those. They're listed sequentially, one by one. The problem list is maintained by everybody. The med list is maintained by everybody. Drug interactions are checked on every prescription. You can't sign the prescription unless you check the drug interactions. We're all working together all the time. Finally, we do these health and behavior screening assessments. Here's one with that. We're going over patient bill of rights, making sure people understand HIPAA, making sure people or we check reading levels, what I'm trying to say, see where people are at with that. We also screen for depression, alcohol use, domestic violence, social anxiety, generalized anxiety, both things that are highly connected to alcoholism, and PTSD at the bottom. Because those things affect a lot of people, from that we have a plan of what we do with a positive screen. These are just mini screens by themselves, tell you nothing. You have to follow up on them. But they do help you, they don't miss people. They don't always get it right, but they don't miss people. So then you can take the information from there and do a bigger screen. We did 12,513 encounters, 2009. We do 0.4 PCP encounters to 1 psychiatric encounter, most of which is counseling, which is the way it should be, I think. Maybe the way it should be in all clinics, but for sure in ours. And this is our 46% Maine care, 26% Medicare, 3% commercial insurance. And that's what we're trying to avoid. That's it. Sorry I went over.